Dear Chairman, ladies and gentlemen, thank you so much for the invitation, and Dr. Bansi, thank you for this fantastic lecture that you have just given. It was very, very inspirational, and I feel, of course, a little bit well taken, coming from a very affluent country and seeing all the challenges that you have. But I hope that I will be able to give you a lot of hope and a lot of optimism, because I have learned that India really truly is the country of technology. And maybe at the end and during my talk you will see that technology will be able to give you a lot of hope for your patients with type 1 diabetes, and I'm very sure that it will help to make India a country where type 1 diabetes can be treated just as good as it is in Germany or any other place in the world. So these are my disclosures. The chairman have already noted that I have past president of ISPERT, and Bansi was so nice to put the ISPERT Clinical Practice Consensus Guidelines Compendium in your conference bag. So everything that I want to say about insulin is in there, and Bansi has already said it. So I will concentrate on a couple of other issues. Of course, we have a big diabetes center in Germany, and we have many of the resources that you might be lacking. But what I want to really tell you from our experience being the largest pediatric diabetes center is that you should try to combine as much your clinical care with research, because research is a motivation for the team, because as we all know, diabetes care is not always easy. But the research really shows you the way that we are heading, and so all of our team is involved in research projects, and it serves as a great motivation. Bansi also pointed out the issue of severe hypoglycemia, and this is why I'm showing you this data from the German DPV registry, and I will come to the importance of registries in a moment. As you can see here, over time in Germany, the average A1C, this is a nationwide registry, has declined by 0.4% per year. So we are always improving. And it's a little bit small print on this side, a very recent publication looking at different ranges of A1C. So those are people in very good control, and so here the A1C is rising. But you see that in all ranges of glycemic control, the hypoglycemia risk is really going down significantly. This is the year 2012, and this is the year 1995. So despite improving glycemic control, the rates of hypoglycemia are going down in all levels of glycemic control. And this, of course, has to do with two things. Number one, education. Number two, working against the hypoglycemia fear of us doctors and diabetes teams. We have to become aware that it is possible to comfort families that yes, hypoglycemia does happen, but it's the wrong approach to keep the A1C high in order to prevent hypoglycemia, because it doesn't work. So it's much better to monitor yourself, try to experience what your bodily symptoms are when your glucose is falling, and of course to do as much glucose monitoring as possible. I will come to that in a moment. You see the paradigm change that has happened in Germany. This is the German health report on diabetes, which we are issuing every year from the German Diabetes Aid, and I can only say this is a very powerful tool to make healthcare policy. And you can see that here in 95 there were still a lot of premixes and 2 injections per day. It has then started with intensified insulin therapy, and it took some time to really convince everyone that that's the right way to do. And more recently, insulin pumps. In our center now, more than 60% have insulin pumps. And again, you may say, oh, pumps are so expensive, technology is so expensive. But if I would have told you that 10 years ago, maybe in 1995, that many of your countrymen in India will have a cell phone in their pocket and are reachable all over, even on the Andaman Islands, you probably would not have believed me. but this is the case. And so just take this situation, take it to diabetes. I want to just tell you, technology will become more and more available and affordable as it really works and helps the lives of our patients. So I truly believe that advanced technology of diabetes has to become more affordable all over the world, and this is why we need the awareness that Dr. Bansi was talking about. This is in German, I apologize, but it just tells you how important an electronic health record is and to really monitor longitudinally what you're doing. You can see here the German average outpatient visits per patient year. We record this in an electronic health record. We compare all our centers year by year, 2 times per year. You see that our center has a very high average number of outpatient visits. So we see our patients for short periods of time, but very often. And this is important for motivation and education. You can see here our A1Cs. This was our best year, green, in 2007. And interestingly, this is the year where we had the most outpatient visits per patient. Then one of our consultants, our experienced consultants, got sick. We were unable to keep this up. And immediately, our A1C got worse. And this helped us to go to our hospital administration and say, listen, we need more staff because our average glucose control is getting worse. And so it's really important not only to do a benchmarking once, but to do it continuously to see, to monitor what is happening in your clinic and take the appropriate steps. And it's also a very powerful political tool in discussing with your hospital administration. Because this is so important, we have created the SWEET project. And SWEET is really a means to establish centers of reference, but also collaborative centers which are maybe not have the full power to become a center of reference, but most importantly, to be able to benchmark what they're doing, compare with other centers, and use all this data for scientific projects. To show you here, this is mainly a European project, but we have now expanded to 31 centers all over the world, and I'm happy to announce that Bansi's center has become a collaborative center in SWEET, so India is part of this, and I hope that many more of you will become part of this initiative, and I'm quite happy to help you with establishing electronic health records in your place, which will be freely available from the ISPAD website. And just although we are increasing the number of centers from 2013 to 2014, the average A1C is going down. And I think the discussion of the data is the most important part here. For example, here you can see centers, different centers. Some are doing very well in young children. Others are doing better in older children. Some are doing good in children with short diabetes duration. Others are doing better in children with longer diabetes duration. So you have many things to talk about. Some people have very many overweight patients. Some people have more hypertension cases. So there are lots of issues, and we have strengths and weaknesses in different areas, and benchmarking helps you at identifying those. Another cross-sectional analysis was the teen study. Again, India participated with 18 sites with 500 participants. And yes, we did see that in a very large group of patients, we still did not reach the A1C target. Those were all young patients all over the world. But again, modifiable risk factors were really the difference between people at target and not at target. So using just a daily fixed insulin amount is probably not a good idea, but you really have to teach flexible insulin therapy, and also you need to teach carb counting. People need to match the insulin to the food that they are taking. So there are many things that we are able to do already now, even without technology, to have more children and adolescents and young people to achieve their optimal diabetes control. I just want to move to technology now, because I really want to convince you that this might be, particularly for the Indian situation, a way forward. There are so many pediatric diabetes electronic media already out there which assist our patients in making the right choices, in trying to figure out how many carbs are in their food, how much insulin to give, how calculate insulin doses. There are more than 1,000 apps that have been looked at, and I'm pretty sure that India could be actually at the forefront of programming clever apps for every situation, for diet activity, for game, and also to enhance the diabetes community. Because, as we can see here from an American example, the Night Scout initiative, diabetes technology sometimes is very slow because we have to think of regulatory issues, and scientific studies take quite a long period of time, and we know that the half-life of diabetes technology is actually 18 months. So once a study is finished, the diabetes technology is already outdated because it's already the next version of diabetes technology. And what happened here, I don't know if you have been aware of that, this is a report from the Wall Street Journal. Actually, parents have hacked a Dexcom continuous glucose sensor and made it available over the internet to cell phones, so that parents were able to monitor their child from far away, from even between continents. It's a technology which Dexcom has now actually perfected more, but it were actually parents who moved forward to that, and the FDA was more or less just watching the whole thing. So we really have to push this area forward, otherwise the parents will do it on their own, and maybe that's not in all cases such a clever idea. And I want to challenge you even more. You were talking about lack of availability of blood glucose strips. It's my prediction that maybe 5 to 10 years from now, nobody is going to measure blood glucose anymore. Right now we have already the flash glucose monitoring, which is not approved for children yet because there are very little pediatric studies, but you can see we have several patients because clever parents simply got the device, and we also have it for research purposes. This is a little continuous glucose sensor which sticks here for 14 days in your subcutaneous tissue. It doesn't hurt at all. You can take showers, you can go swimming. Whenever you want to know your glucose, you simply run the scanner over it. It shows you the glucose. You can see, as in children we often have it, the glucose is all over the place. But it really gives you a lot of new information. With the arrows, you can see the profile. And this comes in Germany at the same cost as blood glucose strips. So if this technology continues to work properly, if we have more studies showing the benefit to it, we probably won't have blood glucose sticks for very much longer. And if just look at it, it's a device for all patients with diabetes. So I think the technology will overtake, and blood glucose strips are a story of yesterday. Now let's move to my favorite pet subject. Last time that I visited Diabetes India 2 years ago, I showed you a movie about the Dream Project about the artificial pancreas. So how far are we? Commercially, you probably read on the internet, on the January 22nd, there was an Australian boy who got the first artificial pancreas. Well, this, of course, is just the latest edition of the Medtronic Minimate pump, but it has something very clever, which really is a first step into artificial pancreas, that you measure your continuous glucose with a sensor, and it shuts down your insulin when it predicts that your glucose is hitting a hypoglycemic target. So instead of stopping at a certain threshold, it now actually is using the continuous glucose information to not go so far down, but stop at a safe area, and thereby even preventing hypoglycemia more. And we have shown in an exercise study that this works very, very well. So how far are we really to close the loop? We have pumps, and they will become cheaper and cheaper. We have, of course, the continuous insulin infusion. And if we lock all this together with a glucose sensor, who transmit the glucose to a computer, or maybe later on to a cell phone or a tablet, then we may be able to close the loop. This is our Dream Consortium, like I talked to you about. So many people multinationally working together and trying to get the closed loop to the patients. I have shown you already last time that this is a plan where we first validated. We did an inpatient study, then we tested in the camp study, which I showed you 2 years ago, and we're now in the situation where this is already available home overnight for study purposes. We at the same time are trying to develop dosing advisors for the day, and then of course trying to close everything to have a 24-hour artificial pancreas, and you see all the publications that are coming out of this project. And of course, this was our camp study, which we did children actually doing a lot of swimming during the day, and at night they were at the continuous closed loop or just sensor augmented pump therapy. Also shows you how important multi-center national studies are, because here the Israel team looks more like a cricket team going out to a match. This maybe looks more like the Slovenian team. They're more disciplined, and the Germans always look like a football team, a soccer team, because that's why we were the world champions last year. So anyhow, this was published in the New England Journal of Medicine. Where did we go from there? Well, others also went other ways. They used glucagon. We only use insulin in our system. I'm a little bit doubtful whether many children in India, with all your temperatures and your wonderful weather, would like to wear so many things on your body. But yes, things will be smaller. But I don't really believe very much into the need for glucagon. I'm a person, in the old days where we had a cold and a hot shower, I always had a big problem trying to get this thing right. So I believe if I have to do the same with glucagon and insulin, I also won't be able to get the things right. And if you look at the paper, actually the insulin levels are pretty high, the glucose level, the glucagon levels are much higher than we usually would have it. And we don't really know what glucagon is doing to your body if you really are giving supernormal glucagon levels for quite some time. So I'm very doubtful whether this is going to be the right way. Anyhow, we are now in 6 weeks overnight studies. They look like this. Whenever the child feels it's their evening, they turn the artificial pancreas on. Yes, they sometimes eat at night. I don't know how about Indian children, if they eat a dal at night when they're still hungry. Well, at least here they are doing it. And the continuous glucose sensor even is able to cope with this. The question, are we able to do it for 24 hours? And now I need that somebody hits the cursor so that this starts moving. Can you just hit it quickly? Yes, just okay. And here you can see what happens for 24 hours. Here is a meal. Here are the boluses. So this system gives boluses as well as changing the basal rate. This is the basal rate. And you see there are so many changes over the course of a day. No patient could ever calculate that. No patient could ever do it. No doctor could give advice how to do it. So we really need the technology. We need the computer advice to keep the glucose in such a wonderful way. So what are we doing now? We have just mentioned at the technology conference in Paris in February that the European regulatory authorities approved that system for use in patients. So this is the number one step. And I'm happy to tell you that 2 days ago we announced that DreamMed, who is working on this closed loop system, cooperates with Medtronic to put this into their pumps. And I'm very hopeful that in 1 or 2 years we will really have a commercially available product. Well, in the end of the day, again, let's ask what the patients are saying, and if you could hit the cursor once more. I apologize, it's German television, but I guess you get the feeling if you're able to hear the voices. Can you put the voice on? This is German, but you can read it here in English, what they are saying.
Also ich will es auf jeden Fall unbedingt haben, weil wir nicht mehr so genau auf die Blutzuckerwerte achten müssten. Und zum Beispiel vom Sport oder generell müssten wir keine Angst mehr vor Unterzuckerung haben, weil das ist ja auch nicht so schön. Und generell müssen wir einfach ein normaleres Leben führen.
Außerdem können wir nachts nicht mehr wieder in Ruhe durchschlafen und müssen nicht besorgt sein, irgendwie unterzuckert zu werden oder hochzuschießen. Und unsere Eltern können auch in Ruhe durchschlafen.
Die Forschungen im Diabeteszentrum Hannover laufen auf Hochtouren, auch auf anderen Gebieten. Wie wird die Zukunft von Diabetikern aussehen?
So, how will the future for diabetes look? I think clearly better than it is now. I realize that 70% of young people right now are not meeting their targets, but we are able to have modifiable factors that we can improve. I think benchmarking will be critical because some people are doing better than others and we can learn from each other. There are so many digital support tools and we need to develop them further. And I hope I have given you some optimistic outlook for patients with type 1 diabetes, because I'm pretty sure diabetes technology will change how we're treating type 1 diabetes very soon. And so with this, I want to thank you for your attention and thank you for inviting me to your wonderful country. My family really enjoyed it very much.